Okay, Walt, you're up.
Good afternoon, everyone. My name is Walter Glum. I'm the Executive Director of the Connecticut Council on Developmental Disabilities. And I'm here to welcome you to the third in our series of webinars about access to healthcare for people with developmental disabilities. Today, we have a panel of experts to speak to us about the special difficulties of individuals, people of color, and people in marginalized communities have in accessing healthcare. I will be introducing them presently. Okay.
This is Ellen Andrews. Just so people have an idea of the logistics, you can use Q&A for questions, and upvoting is active. If you like somebody's question, you can vote for it and move it up to the top of the queue. ASL interpretation, at least right now, is not available, but you can, closed captioning is, and a link to the recording slides and resources will be sent after the webinar.
Thank you, Ellen. So with that, I would like to introduce our first speaker, who is Kati Vieta from Health Equity Solutions. Kati, take it away.
Thank you, Walter. Hi, everyone. Good afternoon. My name is Catherine or Kati Vieta, she, her, ella, and I am the Director of Policy at Health Equity Solutions. I'm really happy to be in this space with you all today. For folks who are not familiar with Health Equity Solutions, we are a nonpartisan statewide nonprofit organization located here in Hartford, Connecticut. And we engage in statewide advocacy to dismantle structural inequities, and we utilize an equity lens across all of our work. So I'm really excited to talk about this conversation, but I wanted to preface it around the fact that when we talk about and discuss barriers to communities that communities of color face, it's important to acknowledge that these barriers are often multifaceted and often compounded by lived experiences related to racism, classism, ableism, sexism, xenophobia, just to name a few, all of which are systematic issues. So with that, I wanted to share some areas that we have worked on to address some of the barriers that community of colors face and play a significant role in trying to eliminate some of those barriers. So the first being around financial assistance as it relates to medical debt. Medical debt is a major area of focus as its impacts continues to grow as a driving factor to the cycle of economic and health inequity across the country. We hear about medical debt in the news quite frequently at this point. And hospitals are really a key driver of medical debt due to the steep growth in hospital prices related to like more costly services that they may offer, but also due to hospital consolidation, which we've seen a lot here in Connecticut over the past few years. In Connecticut, 80% of hospitals are nonprofits with financial assistance policies in place, but those policies vary across the different hospitals. And despite the existence of financial assistance policies, nationally, 47% of people are unaware of financial assistance programs, also known as charity care, and people of color report being less likely to receive information about these programs. This is especially concerning because we know that people of color, especially Black people, are disproportionately impacted by medical debts. So there's a few things that Connecticut can do to address these issues, right? To address these systematic issues. And a lot of these things that I'm going to name were suggested in HB 6740 in this past legislative session. So one of the key things is really creating a universal financial assistance application that can be accepted by all Connecticut hospitals, and ensuring that that application is offered in multiple languages, in large print, in Braille, and other modes of communication to ensure that language access for people with disabilities and people who are proficient in another language can fill out the application with minimal barriers. The second thing is requiring hospitals to screen both insured and uninsured patients for financial assistance program or charity care, again, with the support from language professionals, so interpreters, including ASL interpreters, to make sure that the information is being clearly communicated to patients. And the third thing is requiring hospitals to report how much charity care they're actually offering and who they're suing, with a particular focus of also capturing data on race and ethnicity and language, so that we can identify as a state where disparities are persisting. So all of these things are really important to make sure that we are reducing medical debt in Connecticut. But most importantly, with all these things, the state needs to ensure that there is a enforcement entity or agency, right? If there's no proper implementation and oversight, medical debt disparities will continue to persist. The second thing I wanted to touch on is around diversifying the workforce to improve culturally responsive care and reduce disparities. Investing in a workforce that is more representative of the communities being served will improve access to culturally responsive care, which is a huge barrier for communities of color when we don't have providers who can understand the intersection of our medical needs, but also cultural needs and how they interact with each other. A 2021 Data Havens survey showed that 55% of Black and 24% of Latinx folks felt that their race was the main reason for the lower quality of care that they received in a healthcare setting. And particularly in Connecticut, we've seen the passage of certification for doulas, community health workers, and dental therapists. And all these professions have a few things in common, but I want to highlight two specific things today. The first being that the professionals in these roles are often reflective of the communities that they serve. So what does that mean? It means that they come from the same community as their clients. And in turn, these professions support increasing the number of people of color working in the healthcare sector, which also promotes culturally responsive care, because now we have professionals who are familiar with the experiences of their clients. Specifically in Connecticut, 50% of community health workers are from the communities that they serve, and the impact that they have on culturally responsive care is really indicative when we look at the role community health workers took in the COVID-19 response. The second similarity I wanted to highlight with these professions is that they're all proven to mitigate disparities in health and advance equity by closing gaps between people and health systems. So they're really person-centered and really center the needs of their clients. And this is especially true for doulas, who are key pillars in ensuring that Black birthing people feel safe and heard during and after their pregnancies. So again, Connecticut has made great strides in passing legislation to support these professions. And there is more that can be done specifically around dental therapists here in Connecticut and identifying other professions that should be prioritized for certification and Medicaid reimbursement in Connecticut as well. And the last thing I wanted to the last barrier I wanted to touch on today was around immigrants' access to healthcare. So the Husky for Immigrants campaign in Connecticut has been pushing for Medicaid-like coverage for income-eligible residents, regardless of their immigration status, for the past few years. And this specific policy initiative is critical in the fight for health equity, because undocumented immigrants and immigrants under the 5-year bar are systematically excluded from public benefits, resulting in non-citizens having an uninsured rate about 8 to 10 times higher than like the overall state rate that we see here. So in Connecticut specifically, undocumented folks have an uninsured rate of about 50%, and the overall rate in the state is about 5.1. It might be a little higher now because of the unwinding. And since 2019, we have had public hearings during the legislative session that touch on this issue. And every year we hear from directly impacted community members who either themselves or they have children or a parent or another loved one. I'll be done in a sec. Who may have a disability or other ailments, and how they face discrimination, face language barriers, or have accumulated that, or have a fear of accumulating that, which leads them to forego care. So with that, we're really appreciative of the work that Connecticut has done, but really hope to see where Connecticut can go in following the lead of partners in Illinois, California, and Washington, who have taken the initiative to cover folks across all the age groups. So with that, I look forward to seeing what Connecticut can accomplish and hearing more from my fellow panelists. Thank you.
Thank you very much. Our next speaker is the Reverend Robin Anderson from the Ministerial Health Fellowship. Reverend?
Thank you. Good afternoon, everyone. As it is mentioned, I am Reverend Robin Anderson, the Executive Director for the Ministerial Health Fellowship, as well as a pastor for the Cross Street Church. The Ministerial Health Fellowship is an advocacy coalition that addresses health disparities as it relates to people of color in terms of their health care, health concern, and affordable health care, and really looking and advocating for policy changes. As we all know, that many people of color have all experienced not having a lack of access to medical services, along with not having even in having access to medical services, have not always been treated well. And also, not only that, but also a lot of times have not been seeing people that look like them. Also, as it relates to health disparities and really looking at access and really having access to health care, having access to food, nutritional food, having access to affordable housing that's not environmentally toxic to us in terms of lead poisoning, as well as areas in which asthma takes place. Not having access to transportation, always having transportation to get from where we need to go. And then also the astronomical ways in which we're also saddled with co-pays also that we cannot afford, or just affordable healthcare. Can you just imagine the fact that as a person that is growing up, and you even have children, that you don't have access to healthcare, that you have to make a decision each and every day whether or not you pay the premiums that you have, or whether or not you feed your family. Can you even imagine the fact that here you are in a housing development based on what you can really afford, and then your child has lead poisoning because of the way in which the housing is taken care of. Also, you're living where a plant is, in which a plant that is actually each and every day pouring out toxic materials, in which you are dealing with asthma. You have a child that's also dealing with asthma. And then can you also imagine that you're making minimum wage, you have insurance, but then all of a sudden your minimum, you're making a little bit more, $1 more an hour, and now you no longer qualify for free health care. Yes, we've made some strides in terms of covering Connecticut, but as we look at the minimum wage continuing to rise, then that would also mean that persons are not having insurance. Imagine you come here from another country and you're working in different places and you're taking care of different places, but you have no access to being able to get health insurance where you are. Even though you're working here, even though you're part of the labor force, because of the fact that you're undocumented or that you're an immigrant. Those are some of the things to me that are so important as we look at health disparities, as we look at also health equity, and not really having equal access. And it's one thing to talk about health equity, but also it's so important that we also do something about health equity and really do what we can to open up access to people. Everyone should have a right to health care, and especially affordable health care. Everyone, from the youngest to the oldest, ought to be able to be in an environment in which they're healthy, but even if they do get sick or any other concerns that they have, Everybody ought to be able to have a family dwelling that's affordable, that they may be able to take care of themselves. And also, I should not ever be afraid to go to the doctor because I'm not sure if I can pay that copayment. I'm not sure if I have insurance or not. And so when I get to the hospital, when I go to the emergency room, I have to have emergency surgery because I got to the place where I couldn't stay at home any longer. Those are some of the things that people face on the everyday basis, even as it relates to your oral health. I can't go to the dentist because I can't really afford it. If I get a bill, I'll never be able to pay it. Also, there's no affordable dentist in my area. I have my teeth that I'm trying to keep, but because I'm at the age of 45 and I'm also a person of color, that I have to have all of my teeth pulled out. I have no other alternative because I'm not entitled to special services like as for instance, being able to have a root canal. Those are some of the things that people of color have always faced and continue to face on the everyday basis also. And what is beneath all of that, even in terms of health equity, is structural racism. And so to me, you can't deal with health disparities. You can't even attain health equity unless you deal with structural racism. And so just to tell you a story, imagine being a person of color. You ride home, you have a job, you ride home from work, and all of a sudden everything becomes dim. And then all of a sudden you realize that something is wrong with your eyes. You go to the doctor and you find out that you work for a nonprofit organization of color, in which you thought you had insurance, but you find out that the premiums were not paid because of the payment system in which the nonprofit agency was actually getting paid. And here you are having a big problem with your eyes. You can't see, you're struggling, you don't know what is actually going on with your eyes. And then all of a sudden you get to the doctor and you find out you don't have any insurance. And then thank God the person that was at the doctor also was able to say to you, I don't know what we're going to be able to do. I'll send you to a specialist, but I'm not sure if they'll be able to care for you because of the kind of illness that you probably have and what's going on in your eyes. I'm not sure if we're going to be able to pay for it. And then you get to the next specialist, and the specialist says, in my 35 years that I have been in business, I've only seen 10 cases of this disease that looks like that you have. And it's only found in people that have the sickle cell trait and also people that have Indian ancestry. And you find out, my goodness, that person has both of those things. They have the sickle cell trait. They also have Indian ancestry. And they say there's only 400 cases reported in the country. And it's like, well, how in the world could somebody even deal with this? And so thank God that particular person gets you to the National Institute of Health because they said your eyes are hemorrhaging. And the kind of help that you're going to need some very extensive help to be able to deal with that hemorrhaging that's going on in your eyes. And you're going to need some ongoing care. And with you not having insurance, you could, the prognosis even right now is that you're going to be going blind. Also, and not only that you're going to have this disability that you're going to have to deal with for the rest of your life. And so thank God that person was able to get into the National Institute of Health to be able to get their care. But how about they had to fly all the way to the National Institute of Health each week, sometimes twice a week, sometimes 3 times a week, just because they also had children at home that they had to care for. But all of a sudden they realized that they're not even able to work anymore. And so to make a long story short, that person is legally blind and will continue to need the care that they need. They cannot even get it in their own neighborhood because they don't have health insurance. That person is me. And that's why I continue to advocate that we address health disparities because it's so crucial and so important. We take a lot of things for granted, but people are living each and every day and making decisions about their health and well-being based on the fact that there's structural racism that continues to exist. They don't have access to the care and the services that they deserve to have access to. I think we all can continue to work together. CHWs are so important because they look like us. Being able to be intentional about getting persons in the medical field that look like us and also being able to also think about the fact that from the youngest to the oldest, we need care. And no persons of color should be in a place in which they're threatened as a pregnant woman that within the year that they could die just from giving birth to another child. I hope that through this panel discussion that we will begin to look at ways in which we can seriously pass policies that will deal with structural racism and really help us to really obtain health equity. Thank you so much.
Thank you, Reverend Anderson, and right on time. I like that on a panelist. I want to remind everybody to who are attending to use the Q&A tab to log your questions in so that you may have for the panelists, and then Ellen will be asking the questions after our last panelist. So our next speaker is Graziella Rice from the Yale Program for Recovery and Community Health. Graziella?
Thank you, Walter. I would like to thank Walter and Doris for the invite to present in that webinar today. I will be talking with you about the DLIN, the Disability Lived Experience Action Network, and the work you have been doing for people who self-identify with disabilities in their community. Next. So let's start with why. Why DLIN? Next, please. There are over 6.4 million people in the United States with disabilities. That means 1 in 4 adults. In the 2 past decades, studies has demonstrated that people with disabilities has consistently poor health and wellness care, like you heard from our my colleagues here today. Next. In marginalized communities like Black and African American, disparities are worst. Next. Data collection from American Community Survey in 2023 show increased rates of disabilities for Black population as a Latinx population, how you can see. Next. So for the Latinx community, data may be underreported because of social and cultural barriers, and also because of the issues around citizenship. Next, please. So what we'll be talking here today, it's really about health disparities. So you can see disparities in many different ways I will present here today. So it's related to hopeless policies, limit of access in care, poor working condition, legal status, and much more. Next. So next, please. So as we can see in a recent study that we conduct here at Yale, we published this paper where the results shows that maybe people from Brazil and other Latinx countries from South America, they are invisible as a person, as a human being, when they seek for health treatment in the United States. Next, please. So what are the problems? So why you're going to that? So what are the barriers? What you need to improve? So the DLIN start to study with Latinx and Black communities, and we want to listen from them and work from them. What are the issues around health, equity, inclusion, and make them and share the voices to increase health access and well-being and conditions to live here in the United States. So in order to do that, we are studying and address barriers that we have been listening to from many studies. We will see health disparities in so many studies, but we will not see any studies that it's looking for why Black and Latinx community, it's not engaged in advocacy, what are the issues around allianceship, building community together. And that's what you want to study, understand. So where they are, why they didn't show up, what the family is doing, how they organize themselves in the community, how they ask for healthcare, how they access service. There are a lot of barriers around that. So, and you try to understand the gap and try to build something in response to help this community to get organized and increase engagement and allianceship. Next, please. So what you can say about building community together? What is your process? First of all, we listen to the needs of Black, African American, Latino individuals with developmental, intellectual, and mental disabilities and their families. Then we conduct a series of community conversations and we develop a co-design curriculum with Black and Latino community and their families. So all this co-design curriculum was about their needs and point of views, about the needs they have, because we want to learn how to better build a community together. So then we explore the strengths and the barriers and address the cultural needs of these community members and their families. And our goal is really to create a material culturally competent and friendly to build allianship of these communities, because it's not enough you say that you are cultural, you understand the culture, you want to work with different culture, but if everything that you offer for that community, for immigrants and people who has less literacy and access to information to engage in the same level that people who has more literacy and have more access to information have been accessed service today. Next, please. So our methodology to understand the needs of that community, it's based on community-based participatory research framework. And that is the process that I explained. So we invite community to come, you sit, listen, learn, you build, and then we write, you analyze the data, and you invite them to come back, and you give to them feedback, and they give to us feedback. That is the process to engage community in building with them, for them, and with them to create something that makes sense. Next, please. So our population, as I said, here is specifically Latino and Black with disabilities and their families to address right. Next, please. So our data has been showing us that you have different Hispanic, Latino in the state of Connecticut. And I think it is important to highlight that. So you have people, they are from Brazil, you have people from Mexico, Puerto Rico, Portugal. We have people that self-identify when they ask questions about race as Black American, white Portugal, Black Hispanic, Latino Hispanic, white American, Pardo, because you have that classification in Brazil, Black Japanese, and a variation of race that we will not find in any data here. So, and also we want to know about how they self-identify. So you can see 61% it's family member, 31% it's providers and people who self-identify with any kind of lived experience and disability. Next, please. So we also looking deep and what this community has to say to us. So when they're engaged in advocacy to improve healthcare, what are the fears and what are the barriers that hold these people to move and speak up? So we learn from African American community that fear and oppression, it's part of the action to stand off from engaging in advocacy, because Black community is under fear and oppression and fight for rights and in violence against them. So able to be vulnerable. So normally Black communities see as a violent. So they have that fear. So engaging and advocacy could be seen in very wrong and difficult ways that will not be helpful for them. So for Latino Hispanic, feeling guilt, resulting in isolation, the family hide the problem they have, there is a lot of stigma around how you ask for help, and it's the family fault or they did something wrong. It's a lot of spiritual and religious stigma connected to ask for help and also engage in activities to advocacy. And knowledge about language, because they don't have the right English, they don't have this beautiful pronunciation in English, they make people understand what they want to say. For Latinx Brazilians, they hide because they don't feel they are accepted in society. They are quite afraid because they don't know how to behave and express themselves. And knowledge of language, it's a huge barrier to access healthcare because there is a few information available in Portuguese. Next, please. So some quotes from our qualitative data. We will ask the importance of community meetings to create allianceship. So they said we need to hear beyond what we can hear, and we need to speak beyond what we speak because there are others among us here. Next, please. Another important date was advocating structural change. People who live and experience the various communities that we are a part of should get together to create awareness and desire to upfield our communities. Next, please. Another data. Next, please. So building community allianceship and belong. So you ask then, what are the teams that will be great to then to facilitate conversation at the community and bring people and increase allianceship, increase the voices. So as a result of a co-designer curriculum, they shows that knowing my rights, and they need to know more information about advocacy, education, and health. And health was one of the most difficult aspects for them to understand how to navigate in healthcare system in the United States. Employment, healthcare, intimate relationship, and stigma. And they ask that we ask access to information through language and literacy. And they told us if you want to have more advocates for that community, the first step to become an activist is having access to information. Again, access to information is a huge barrier. So I would like to thank you for the opportunity to present here today.
Well, thank you, Graziella. And now to bring us home, we have Adriana Ramirez from the Connecticut Family Support Network to talk about work they've done with the Connecticut Department of Public Health. Adriana?
Good afternoon, all. Thank you for having us here today. Again, my name is Adriana Ramirez. I am the Assistant Executive Director of Connecticut Family Support Network. We are an organization that exists to support families raising children with disabilities and special healthcare needs through the lifespan. And through our work with DPH, as we receive funding from the Department of Public Health, this past year, we partnered with DPH to host focus groups for the Maternal and Child Health Block Grant. Now, some of the data that I will be presenting will be public once the main site publicizes the report, which I will share a link with Walter, and you will be able to access once the 2023 report is up on the website.
I apologize for the interruption, but the other interpreter has finally arrived, and I'm watching the working interpreter and just needed to let her know that I'm here to take over for her. We can't see each other. I apologize again.
Thank you.
Sure, no problem. So again, the Maternal, Child, and Health Block Grant, it is the department, DPH gets funding from the federal. These funds are for preventative and primary healthcare services for pregnant women, mothers, and infants, preventative and primary health services for children, and services for children and youth with special healthcare needs, including behavioral health needs. So this is the information that we were helping them by providing space for focus groups with our families, along with other families. After the information, DPH writes up a plan and talks about how they can improve services in each of these areas based on some success measures, including these focus groups. So the focus groups is one way that they can share, families can share their experience and how they're receiving health care, and also suggest ideas of how the system can be improved. So we had, with DPH, there were a total of 6 consumer focus groups, 2 of which were Spanish speaking, were completed again in collaboration between DPH staff, family representatives of the Medical Home Advisory Council, and Connecticut Family Support Network, for a total of 35 participants. The focus groups were conducted virtually, and consumers identified using the maternal and child health services. The data is not disaggregated by language or race, but there were, out of the 35 participants, 20% were men, 77% were women, and 1% did not provide a gender. For racial ethnic composition, there was 54% Hispanic, 14% Black, 6% multiracial, 3% Middle Eastern, 3% Asian, and 20% who did not provide any race or ethnicity information. So I'm just going to briefly go over highlight a few of the questions that were asked and some of the responses of the focus group. Right now, excuse me, they asked, what type of services do you need or require? The most popular response, 26%, involved different types of therapy services and programs like speech therapy or swim therapy. They also included in-home and out-of-home programs. Also identified this year was the need for specialty dental, optometry, and audiological services, especially those providers specializing in working with children and youth with special healthcare needs. Now, the second question was, how can finding these services be easier that was asked to the families? The number one answer was to have more providers and facilities available, 36%. This was up from last year when only 9% of the respondents said they needed more providers. They also included the second hand and were experiencing long wait times to get services. The second most popular answer this year was to simplify what is available. So 27% response, which includes making sure handouts are in plain language, making the 211 website user-friendly, making sure phone numbers are available and easy to find, and having a list of provider services available to families. And again, it's just accessing, just the availability to access supports that they need in their plain language and in their own language. Number 3, who helps you get appointments? Now, this was up not significantly, but enough that it made a difference. Just as last year, it was still the same response. It is the families themselves that are responsible for making all appointments, being up 67%. Who would you talk to if you had concerns about your child's behavior or what is happening with your child? The primary response was still a doctor or pediatrician at 38%. Second was your organization and schools. What would you do if behavioral or health services were not working for you? Most participants said, 29% said they would seek services like support groups, specifically with the organizations that DPH is working with. Secondly was different medical providers at 20%. That was different than compared to last year. What would they do if they didn't receive services? They would just make a formal complaint. So this year, most families looked at support groups as a way to connect when something is not working in either behavioral or healthcare services. If you do not have insurance available through your employer, Medicaid, or the insurance exchange, how would you access health insurance coverage? The answers were similar. They would connect with organizations, clinics, state agency, having the most responses at 38%, and 19% stated they would go without. They don't know what they would do. Another part that we talked about is, are you receiving telehealth or tele-audio services? This year, there was no differentiation between, it was just bunked together, and they said 69% said they did. And then the second part was, what do you like or dislike about it? Participants provided their likes and dislikes. Many had things they really appreciated about telehealth, but recognized some limitations of it. They liked that they did not need to travel to appointments. It was easier and convenient, but at times health issues still was lacked to be able to see telehealth, things such as privacy issues, technical knowledge, appointments being too short, and families not comfortable with some of the appointments being just asking questions. It was more of asking them to partially assess their child and give feedback. The last question that they asked was, as the pandemic has continued, have the services you have received improved over the last year? This year, only 32% of people said that services had improved compared to last year, which was 41%. Many people felt that services were very similar from the previous year, with their PCPs being more open, but they noted that while there are fewer cancellations, there are much longer wait times to get appointments. And overall, from the focus groups, many families would speak to, especially those families that had multiple children with disabilities, especially intellectual, developmental, behavioral disabilities. Let's say they had a younger child and they had a child over the age of 18. They mentioned the second cliff, the first cliff being transition out of school to adulthood, and the second cliff is transitioning from pediatric medicine to adult primary, and the availability of having access and accommodations, including long wait times where they sometimes cannot stay in an office waiting for the appointment to happen while their child is potentially uncomfortable, or sensory issues, or there is concern about crowding, and there is no accommodation for these families to be able to, let's say, go to a sensory friendly room and having to leave an appointment and then having to reschedule and potentially wait another month to 2 months to get a new appointment. So families are asked, and they asked for more training to offices and providers, such as sensory, and being able to make accommodations for families specifically with disabilities and intellectual developmental disabilities. Specifically training, having those rooms available. We know that sometimes construction expansion is not always the first possible thing, but there are other measures that can be taken that can be done right now. Also having appointments and really understanding the nuances of what families are going through. And then when you add a second layer of language access, so you have the barrier of having accommodations, and then you have another barrier when it comes to language access, whatever language that is, and having the availability to express themselves, especially when it comes to referrals. Majority of the focus groups that I attended, families were left to make the referrals themselves, and said navigating the system of referrals through call centers, accessing someone to speak to in their language, and just trying to get through was very difficult to get through a referral. And it could take a long time to finally access, or they would reach out to their community friends, family, or community organizations to help them navigate that system. When other referrals are made, they've talked to someone else that maybe their system is different, and the referral is made by the actual doctor, and they do not have to call themselves. I speak pretty quickly. So we are looking forward to continuing our focus groups. Right now, we are in the process of working with DPH, and we are scheduling 3 Spanish-speaking support groups, and then we will be having a few more in the next year. We are looking at expanding the data, because we see how important it is to provide this information directly from families, and to provide it to those policymakers and to those that will hear this and understand what families go through with disabilities, language barriers, families of color, to really understand how we can make a difference and how can we truly impact those families and support them. Thank you.
Thank you, Adriana. Now, I want to remind again everyone who's participating to put your questions in the Q&A tab. so Ellen can read them. And in the meantime, I'll start with a question for the panel, and that is, if you were to ask, what's the one thing that you would ask the governor and the legislature to do in the next year to improve access to healthcare? And if someone doesn't volunteer, I'll start picking on you.
Now I can do it. So I think you need to improve access, provide information in different language. So we have data here in Connecticut that you can see Hispanics and other communities. I think that's a simple way, actually, because we have so excellent technology today that it's just about to, you know, have that information, have a good agency to work with the state and provide that information in different language, because access is also relates to what people knows the rights they have. And we have been listening from our community in Connecticut every time that we meet with them. The language is a barrier, and inform people to let them know how to navigate in a healthcare system is extremely important. So I think that should be the first step.
I
Thank
think,
you, Graciela. Reverend Anderson?
yes, I think also what is also extremely important also is that really knowing that everyone ought to be able to get health care. And so how is the way that you do it? Of course, that you want to at least raise that income level, even for cover Connecticut, to 200%. The minimum wage is actually getting ready to go up again. And so that would also put a lot of people not eligible for insurance. I do think that also, even as we look at payment options as it relates to community health workers and also doulas, I think we need to really pass policies this time that would also be able to move that forward. You know, also, and of course, affordable housing. We're living in a time also in which even construction and everything else that's going up is actually for luxury housing. And also the regentrification that continues to take place, which of course, once again, puts persons out of that are of color not being eligible for various housing, and also will continue to keep them stuck in environments that will continue to contribute to the disabilities that they face, also being and not having access to services, and especially healthcare concerns that plague us in those communities, especially environmental, such as asthma, also heart disease, diabetes, and some of those other things that because of our lack of access to food and good food, we still have persons that, you know, people in Connecticut, one of the richest states, that don't even have access to grocery store or access to fresh vegetables or fruits. And even when they go to the line for the food kitchens or the food, also for the food pantries, a lot of times they are foods that are given out that have high sodium, also that also have also pasta and all of those things that continue to contribute to the number one things that people of color continue to die from. And that we would just really look at ways, as we talk about equity, that people would not die of color at a high rate that they're dying, that are higher than other counterparts. But what are some of the things and policies that we need to make and change that people of color would have access to medical services that they so rightly deserve, as well as the social determinants of health that continue to also exist? How do we also make sure that those social determinants of health are actually a reality and not that, but there's something that they have full access to that will continue to help them to stay healthy?
Thank you, Reverend. A question for you and for Catherine. Can you speak to the potential role of community health workers in addressing these issues? Catherine?
Yeah. So I know earlier I spoke about the fact that community health workers are really representative of the communities that they serve. But community health workers also play a really critical role in identifying additional resources that community members might need to address some of the barriers that Reverend Anderson was just discussing, right? So housing, like supporting and making the connection to the proper either community-based organizations or other like state-based resources that folks can tap into and apply for to make sure that not only their clinical and medical needs are being met, but that folks' social needs are also being met, right? Our well-being isn't just based on what happens in a medical room or in the clinic. It is based on our environment as a whole. So that's one thing I will say about community health workers. Community health workers also are known to reduce or support in the reduction of hospital readmissions, right? Again, because they're able to support people acquire the resources that they need. But also they are really a key role in promoting health literacy and culturally appropriate care, which is important to make sure that people feel seen and heard and respected in the care that they are receiving, right? We don't want people to just like receive care based on like the lens of what the provider thinks is good quality care, but based on the actual social, cultural, and medical needs of the client.
Thank you.
Walt, we do have a question from Doris Maldonado Mendez. What are your successful best practices for educating and engaging legislators in Congress? The HELP Act in 1964 Civil Rights Title VI language access and executive orders providing access by federally funded organizations and health providers. Not sure who wants to handle that one.
So the question is, what are your best practices for language access to satisfy?
I think for engaging legislators in Congress in enforcing language access.
Does anyone want to speak to that? Adriana?
We're trying to unmute myself. So, personally, from my experience, it's really getting the community together to come together and express, just like we've been having some of the legislative meetings about health access and getting the information out to families through focus groups and getting that awareness to legislation of the need and the growth. And from all the information that everyone has given here, the positive results and impact that knowledge in your language to be able to access health. And as everyone said, it's not just at the medical office, it's health holistic, because it all is a chain reaction. So if you're missing one link, it will create weaknesses in other areas. Well, it will impact health in general. But for language access, it's just working together and showing the opportunities that we have and collaborating together to show legislation that it is something that is doable and accessible by working together with community and legislation and stakeholders. It's not one or the other, it's everyone working together.
Doris just clarified, she was talking about the Senate Help Committee. So I think she's talking more about at the federal level. That those laws, those laws are at the federal level, and how do we talk to people at that level to make sure that it gets enforced?
Well, if the panelists don't have an answer, I'll throw in.
Yeah, I could answer that. I know it was about language, but I do think that again, we sometimes forget that persons at the federal level are also working for us also, and should be working for us, and that we actually elect them, on the federal level as well. So I do think that a big part of that is also, just like we're having these panelist discussions, but it's nothing wrong with also inviting also persons on our legislators on the federal level, as well as, being able to do advocacy work, on the federal level, but even talking to our local legislators and even asking them, what are some of the ways in which they're engaging, legislators on the federal level to be able to address, some of these things, especially language and all of those kinds of things. Because I do agree, that we do, sometimes we kind of stay on the federal, on the state level, but, some of these things in terms of policy changes that, will be effective, not just even in our own state, but throughout the nation, is also some of those decisions are definitely made on the federal level. So I think we have to engage our federal as well as our local and state government.
Thank you, Reverend Anderson. I just wanted to add that, as Doris points out, language access was in the '64 Civil Rights Act. So this is a requirement, a federal requirement that's been around for 60 years. And there is a U.S. attorney in the state of Connecticut that's responsible for this from an enforcement standpoint. I'm not sure what new legislation we might need, but there is a citizen complaint channel. You can contact the U.S. attorney in the state of Connecticut and file a citizen's complaint about violations of the Civil Rights Act. And maybe that's something we need some more education on. If the issue is enforcement of federal law, that is a matter for the Department of Justice. We're coming to the end of the hour, so I'm going to.
I just wanted to, Doris had another follow-up. She wanted to thank you, Reverend Anderson, and also said the council has been in discussion with our congressional reps, the Connecticut congressional reps. And I just wanted to add that they are very interested. I used to work for legislators. They are very interested in hearing what you have to say. You definitely should call them. Don't be intimidated. There's lots of help out there if you want help to think about how to reach out to them, but they want to hear from you.
Okay, then. I want to thank everybody. This has been another great webinar in the series. We will be back in 2 weeks with a webinar featuring some promising practices from other states. We're going to have physicians and policymakers from Maine, New Jersey, and Colorado speak to us about the work they're doing. I want to remind everybody to complete the evaluation. There's a code on your screen, and I hope to see everybody and more here again on October 31st. Thank you very much.
Thank you.
Thank you very much.